Thank you. Thank you, Yusra. Good evening, everyone. My name is Hadija Luvuno, and once again, welcome to this webinar. This is a continuation of our last week's session on the second step of Kaizen procedures with QC story. Sorry, just trying to, thank you. So in our last week's session, we tackled situation analysis in Kaizen. And we said that situation analysis in Kaizen is the process of identifying the magnitude of each contributing factors to a challenge. And this process involves data collection and of course, use of the Pareto rule in a Pareto chart. Point to note that the methodology we use in this step will be used when we are tackling step 6. So we need to be very attentive because the same procedure will be applied when you're collecting data to check effectiveness. We looked at this picture last week in our webinar. Just to quickly go through it, this is a connection between step 1, 2, and 3 of Kaizen. In step 1, we identify the theme. Of course, it has to be put in a positive way. And then from the theme, you need to tell everyone in a more comprehensive statement what the problem is and how it affects you, where exactly does that problem occur, and what will happen if you do not handle that problem, or why did you choose that problem? So from your theme, you need to unpack the contents of the challenges, or maybe in a deeper meaning, try to appreciate how much each content is adding up to your challenge using a tool called a Pareto chart. The contents are the contributing factors, the green balls here. And I remember we also said that depending with the magnitude of each contributing factor, the factor that carries a heavier weight is what we take to our step 3, which is root cause analysis. Using the same tool, the Pareto chart, we'll be able to see which factors carry a heavier weight to our problem. Then the root cause analysis, or step 3, Kaizen, is where now we find out the reasons why the problems are occurring. So this is also a reminder of examples of contributing factors. If you choose a theme, or maybe if your challenge is incomplete documentation of patient's treatment record, what are the contributing factors? The contributing factors are the parameters in a treatment sheet or treatment recording sheet. Actually, what we're trying to say is you look at the treatment sheet or the prescription, whatever you call it, and see how much each of the parameters I mean the biodata of the client, the diagnosis, maybe the lab results test, you can also add the radiological investigation results, the signature, etc., etc. That is what forms a treatment recording sheet of a client. So if we say we are incompletely documenting the treatment sheet, it means one of the parameters or some of the parameters have not been documented. In quality, it is either a yes or a no. So if you miss some of the parameters, if you do not document in some of the parameters, it's as good as you've not done anything. So contributing factors in incomplete documentation, you'll be looking at the parameters. Is the name included, the age, the weight of the client, the diagnosis, etc., etc. Another example is when you say you have low under 5-year under 5 years triaging in a facility, what are the contributing factors? The contributing factors here are the triaging indicators. And the indicators are actually guided. They are written in MOH 204A. For you to say that you have triaged an under 5-year-old child, you must take all the 7 parameters: the height, the weight, the MUAC, the oxygen concentration, the respiratory rate, and the pulse rate and the temperature. If some of these parameters are not well taken or they're not recorded, then we say that you have not triaged an under 5-year-old child. Remember, these are based on guidelines, which are our standards that we use. So these are the contributing factors. If there is anything that is missing here, then we say it is contributing to our low triaging coverage. I'll give another example on turnaround time in a facility. When we say high turnaround time in a facility, we mean that clients stay for longer than required or than expected. Of course, our standard would be on the service charter. The contributing factors are actually the departments which clients pass through. The triage department, the records department, the consultation department, the laboratory, pharmacy, and also including the miscellaneous time. Here, by miscellaneous time, I mean the time taken between two departments. The time you take between triage and record. You've just concluded triage and you want to be served in the records department. There's this time that you wait before you are served. Then there's this time before, after you're done with the records department and you're waiting for consultation. There is time that is also being wasted. So if we add all this time from triage department up to the last point where a patient visits, that is when now we can say either clients overstay in a facility or they take the required time. So the contributing factors to high turnaround time or turnaround time in a facility will be the departments where clients pass through to seek services. Just to add to our examples, we can also look at low family planning uptake. When we talk about low family planning uptake, the contributing factors will be the available FP options or family planning options in the facility. Example, the long-term and the short-term. We can look at IUCD, implants, injectables, and even the oral family planning. So when we say we have low family planning uptake, it means we're either not covering enough in terms of these methods. I can also give an example on documentation. When we say incomplete documentation in a pathograph, that's a challenge. So the contributing factors are actually all the parameters that are supposed to be filled in a pathograph. And that includes the patient's biodata. We can check on cervical dilatation, the descent. If there is any parameter that has not been recorded, then we say that that pathograph has not been documented, completely documented. Remember, these are different from root causes. Is it clear? I hope that's clear. So let's have a small challenge on these two challenges or themes: missed appointments among CCC clients and low TB screening uptake or coverage. Back to you, Yusra. Kindly lead us in this. Let's see if people understand. What are the contributing factors to missed appointments among CCC clients? Yusra? Yes. Back to you. Kindly lead us in that.
Okay, let's put in our chat box or raise hand if you want to speak up. Okay, someone is saying stockouts.
Mhm. Any
Okay,
other
Margaret.
trial?
Okay, Margaret is saying long queues. Lau is saying failure to keep appointments by patients. That is CC patients. Okay. Sophia is saying lack of triage facilities. Stephen is saying lack of transport fare. Odero is saying screen tool. Julia is saying failure to write return dates. Margaret
Set
is
a time.
saying
Sorry,
lack
Yusra. We didn't set a time for this exercise. Sorry. Maybe we can set a time so that we don't.
Okay. We'll take only the next 10 seconds. So Margaret is saying lack of clear communication on TCA. I think that's all. 10 seconds are over.
Okay. Maybe we can go back just a little. Okay. For contributing factors, we said we are actually unpacking the contents. We are not looking at the reasons why these clients missed a CCC appointment. We are looking at what are the contents of who are supposed to actually come to these CCC clients. We can look at it in terms of the different cohorts. Because if we look at, if we talk about lack of transport and tools, then we're looking at reasons why clients never came for the appointments. We are not actually supposed to be looking at reasons at this point. The second step of Kaizen with QC story, which handles contributing factors, we are looking at the justification. Why do we say we have missed appointments? How can you justify that you have missed appointments? Perhaps you can look at it as in clients who are supposed to have come and have not really shown up. What are the different cohorts that are supposed to come to a facility? Is it clear? I think that's a bit different from the root causes. Let's make another attempt. Low TB screening uptake. Maybe this time we need someone to raise their hands and tell us why they're choosing that answer, the answer they want to say. Yusra, please.
Okay, Hadija. Okay, somebody maybe to raise hand if you want to speak up. Okay, Peter is saying entry point, age cohort. I think he was answering the appointment keeping.
Mm-hmm. Thank you. Someone has risen their hands. Sophia Ali, Yusra.
Okay. Sophia, please unmute and speak up.
Okay, Assalamu alaikum. I'm Sophia Ali, TB coordinator for Kamkunji sub-county, Nairobi County. And I find a challenge in screening for TB, especially in the private facilities who don't have triage. They do not have triage facilities, so it's a challenge. We have a challenge in screening. And in our public facilities, sometimes you don't have a screener. If you don't have a screener, then you find that the nurse who is on duty on that day is working in the TB clinic. She's the one doing dressing.
Maybe just to interrupt,
to
Madam
other patients.
Sophia.
So you find that there is a challenge in screening. So most of the time you find that she's not screening. And yes.
Sorry, Sophia, to interrupt you a little.
Yes.
Tell us the justification for low TB screening. Don't tell us why screening